pretty fast. So this talk is on pre-hospital management of cervical spine injured athlete, looking at an evidence-based approach and practical management. Disclosures again, I do instruct for Sports Medicine Concept, which is an organization that goes around doing the 2 minutes or less instruction at various schools. We've added several NFL teams and several NHL teams where we go in and work with them. And then I am a member of the Spine Injury and Sport Group, which I'll talk about a little bit later. Our clinical question for this is athletes, both equipment and non-equipment laden, requiring acute cervical spine injury management due to current pre-hospital management recommendations of impact athlete outcomes, meaning increased stability, decreased pain, space available for the core, decreased range of motion, and management and access to airway, breathing, circulation. So these are our objectives. We're going to look at what the current recommendations are, identify the role of the athletic trainer within the interdisciplinary healthcare team, look at the current scientific evidence related to the management, and talk about the skills needed for the management of a cervical spine injury in the athlete. Again, you're not studying or practicing for the exam. You're studying or practicing for the day where you're the only thing between the athlete and the grave. Looking at interprofessional practice, a term the NATA probably 5-6 years ago made an emphasis to teach in its education programs, talking about interprofessional practice. When you do some of the research behind interprofessional practice, you see 1910, Dr. Mayo came out with this statement of the best interest of the patient is the only interest to be considered, and a union of forces is necessary when dealing. So they were talking about interprofessional practice on the physicians all the way back in 1910. The definition is the provision of health care by providers from different professions, provided in a coordinated manner, and by professionals who share mutual goals, resources, and responsibility for the patient. That's what we do every day. When this first came out and people were talking about it and people were telling me they went to 4 or 5 day seminars about interprofessional practice, and I'm like, okay, that's just teamwork. Everybody working together, leaving your ego at the door, and working as a team for the best interest of the patient. So I'm sure everybody has stories about turf battles and battles you've gotten in with EMS and different things on the field with regards to the management of an athlete. The big thing I always stress is leave your ego at the door. No one gains unless we all gain. We have to have those interprofessional relationships, and those usually start with communication. Those usually start with working with the various entities that are going to be involved in the care of the athlete, making sure that we're training with all involved people, that you're having joint training sessions, tabletop exercises with your fire, with your EMS, with your ER staff as to what's going to go on with an emergency situation, how is it going to be handled, but getting that done beforehand. Leadership, fellowship, and relationships. They're not mutually exclusive. You can be a leader 1 minute, you can be a follower the next, back to a leader, back to a follower. If the appropriate relationships are built, you should be able to go seamlessly back and forth between being a leader and being a follower, back to a leader and back to the follower. And when you think about it, there's no better example of this than a cervical spine injury on the field. You're going to be the first one there as athletic trainer. You're the leader. You're telling people what to do. EMS gets there. You may have to go back to being a follower. When it comes to taking off equipment, you're probably going to be more versed in what equipment that athlete's wearing and how they're wearing it and how to get it off than EMS is. You're back to a leader. Once they get on the cot and into the ambulance, you're back to a follower. You may get to the hospital and you didn't get the equipment off before you got there. Now you're with the trauma team. Now you're back to a leader with the trauma team as to how you're going to take that equipment off. You have to communicate and you have to build relationships. So pit crew concepts. This is something that is big in EMS right now. If you Google pit crew CPR, they will go through and they'll show you what they mean by pit crew CPR or pit crew concepts. It's basically taking what's done in NASCAR and Formula One and everything about how do you jump over the wall, how do, I think it's 7 people jump over the wall and get 4 tires and a tank of gas in under 10 seconds. And if you ever watch NASCAR, you see that hundredths of a second make a difference in the driver going from 4th place to 1st place on a pit stop. So it's a systems-based approach. Every person has a specific pre-assigned duty. As people add to the system, as people integrate into the system, you're adding interventions, but it takes frequent practice. It's something that you have to practice. You can't just rely on a time when the injury happens in order to have this approach. So dealing with pit crew concepts, what I like to call the critical care triangle. Okay, and who's involved in your care at all different times? Who is your critical care triangle on the field? Okay, who's going to be that A person that's generally going to be at the head? Who's going to be that B person? Who's going to be that C person? Think about a game day and then think about a practice day. Who's that critical care triangle at a football practice? Who's that critical care triangle at a basketball practice, at a volleyball practice, at a lacrosse practice, at a baseball practice? Who's going to be involved? That critical care triangle, in most cases, in a high school situation, a coach has to be involved there. Okay? Most times, a coach has to be involved in that critical care triangle. Have you worked with that coach? Have you worked with that coach to be involved in that critical care triangle, to be able to function and act when that athlete is dead on the field? So what do we know about cervical spine injuries? Sports participation constitutes one of the most common causes. Our wild card is sports equipment. There's a huge impact associated with cervical spine injuries. If you talk to United Educators, which is a risk retention group out of Washington, D.C., represents about 3,000 colleges in this country, as their overall insurance company represents thousands of high schools. They will insure everything about a college. So if there's a fire in a dorm, United Educators pays. If somebody trips on the sidewalk, United Educators pays. They talk about sports-related injuries account for 9% of the number of claims that they deal with, but count for 25% of the amount of money that they pay out. So you see that sports-related injuries has a huge financial impact when it comes to lawsuits. We know that airway compromise can happen. We know effective airway management is imperative. We know that airway management must be mastered by pre-hospital personnel. We know that equipment, the same equipment that's designed to protect the athlete, will become a hindrance to prompt care in the event of a serious injury. Again, we know times of stress, you always fall to the level of your training, not rise to the level of your expectations. We know the acute phase of cervical spine injury management is critical. It's critical to manage that. We know the improper handling puts the patient at risk. We know that 3 to 25% of the injuries to the spinal cord occur during the management of the injury, not during the initial mechanism of injury. We know that emergency management and cervical spine injury management is a component of who we are as athletic trainers. Okay, but we're both lucky and we're unlucky. We're lucky in the fact that we don't have to deal with it that often. Okay, but we're unlucky in the fact that we don't have to deal with it often. We don't have to deal with airway compromise in an athlete that often. But when we do have to deal with it, it's a big deal and we need to be prepared to do it. We know that there's no such thing as always and never. Every emergency situation is different. Every patient is different. We have to use our individual circumstances to dictate our appropriate actions. Again, we know if it's predictable, it's manageable. Okay, if we can predict that a shortstop, a third baseman, and a left fielder can collide on a baseball field and all be unconscious and not breathing, we should be able to manage that situation. We should have a plan for how we're going to manage that situation. We can predict that 2 football players are going to collide and both be unconscious, not breathing, no pulse on the football field. We should be able to manage that situation at all different times, not just on game day, but also on practice day. We always talk about cervical spine injury management. Every time I hear a talk about this, I hear about, well, on game day we have X. Okay, we always have a doctor on game day. We always have EMS on game day. But think about it. This is just a little thing I calculated last year of, in a college football season from start to finish, if you go all the way through the national championship game in a college football season, including the 15 days that we get for spring football, you have 162 practices in anywhere between 13 to 16 games. Okay, so your practices are accounting for 91% of the exposures of that athlete. Think about a practice situation. We have less ATCs. There's usually no physician there. There's usually no EMS right there. EMS is anywhere between 7 to 10 minutes away if you're lucky, if you're getting your first due EMS, if there's not something else going on in the county, and you have more student athletes participating. Okay, you think about the University of Michigan. We know on a game day only 70 players can dress for a game. On a practice day, we have 150 players that are all going on at the same time on multiple fields. So multiple things can happen. So in 2001, the NATA came out with an inter-association consensus statement. That was replaced in 2009 by a position statement by the NATA. February 2015, there was a summit known as the Inter-Association Task Force for the Care of the Spine-Injured Athlete. The NATA came out in June 2015 with an executive summary talking about the care of the spine-injured athlete. They've never published the paper from that because there was some debate among some of the organizations as to a couple of the things, but this still, in some respects, is live today, but in some respects, it's not live today because it's never been, the research behind it's never been published. That task force talked about a paradigm shift and how we manage cervical spine injuries with regards to equipment removal, with regards to use of spine boards, with regards to advanced airways. And we're going to go through some of the recommendations in that task force came out with. So this past March, they put together, the NATA put together what's known as a spine injury and sport group. The charge is to develop evidence-based best practice recommendations for the pre-hospital care of the spine-injured athlete. They're going to go through a systematic review, modified Delphi process, and then in January, February, we're going to have the first national conference on spine injury in sport. And it's going to be modeled after the Berlin conferences with concussions. They're going to use that same exact process that they use with all the concussion conferences, and hopefully next year at this time there's going to be published a consensus statement on spine injury in sport. That's hopeful. We hope to get it out by the NATA convention next year, but we're going to take a systematic review of everything regarding the spine injury in sport. So going back to some of the NATA recommendations from the 2009 paper and the 2015 paper, general recommendations, everybody should be familiar with the protective equipment, manufacturer's recommendations, fit and maintenance. University of Michigan, we have 6 different helmets that our athletes will wear and over 85 different face masks that our athletes will wear. We have 7 different types of shoulder pads that our athletes will wear. So we have to be cognizant of all that, plus what's going on with the visiting team. Individuals should be responsible to educate coaches and student athletes. Okay, how many people spend time educating your student athletes of what to do in a serious injury, what to do when the patient's lying down on the field, not to move them, not to try to pick them up? How many people spend time educating your coaches on a Tuesday afternoon practice at 5:30 in the afternoon when you have no doctor on site, you have no EMS on site, you're the only athletic trainer on site, but you have a football player down on the field that's not breathing, no pulse. And the only people that you have there to help you are your coaches. So how much time do we spend with our coaches talking about, this is what you're going to need to do to help me. This is exactly what you're going to need. This is where you're going to be. Make sure the C-spine's in neutral position. Attempt to expose and open the airway, causing as little motion as possible. So thinking about this and bridging the gap situation, what personnel are involved in the management of your emergency situations at all different times? Who's going out on the field with you? Who's going out on the field with you at practice, at a game? What happens? Who's helping you before EMS arrives? If you have a patient that's not breathing, no pulse, and EMS is 7 minutes away, you need to do something, or EMS is just going to come with a white body bag and put the body in there. Because after 7 minutes and no pulse and not breathing, that person's dead. So who's going to help you at that situation? Who's going to help you with an unstable patient? Who's going to help you after EMS arrives? What are you going to do with the visiting team? How do you handle a visiting team scenario? Okay, and think about this. Is a coach, a strength coach, a student athletic trainer, or just a student who has been trained with the athletic trainer and the various equipment and techniques suited for involvement at various times? Can that coach help you? Can that coach do CPR? Can that coach help you take equipment off? And we're going to go through some of that. So looking back at some of the task force recommendations, recommendation number 1, emergency action plans. I'm sure everybody has an emergency action plan. Making sure we're developing it with EMS. Making sure we're taking a time out. Before events, every single event, a practice, a game, whatever, you're taking a time out to talk about what's going to happen at that event. Taking all the healthcare professionals, all of EMS, the visiting team athletic trainer, going through your pre-event checklists. Who are the personnel? What are the roles, responsibilities? Communication. What are the resources? Where are we transporting to? What potential injuries or potential issues could you have? Okay, some things to think about in your timeout. Who's running a code? If you have a code at the stadium, who's running it? Is the doctor running it? Your doctor may be an orthopedist. They struggle to figure out which end of the stethoscope to put in their ear. Okay, is that the person you want running your code? Is the doctor the person you want doing CPR? Probably not. Who's running that code? Who's responsible for the advanced airway? Okay, just because your physician may be ACLS trained, they probably haven't put an advanced airway in since the last time they did their ACLS training. Who's the most qualified person to put that advanced airway in? When do we move or transport the person off the field in a CPR situation? Okay, we'll talk more about this, but this is a big topic in the NFL about if you have a CPR situation on the field, are you going to stay and play for 20 to 25 minutes, or are you going to load and go? Okay, are we removing equipment on the field? And if we are, when are we removing it? How are we removing it? How are we immobilizing off the field? Are we using a rigid spine board? Are we putting this on the stretcher? Are we using lift and slide? Are we using log roll? What facility are we transporting to, and how are we getting there? One thing we've started doing is making sure we have a roster of player weights on game day. So our head athletic trainer carries a current roster with all of our player weights on game day. That way, if something happens and EMS comes, we can hand EMS that roster, and they have the kid's exact weight on game day. So there's no guessing, is this a 250-pounder, is this a 270-pounder when it comes to the different medications that they have to administer. And what are we doing with the visiting team? How are we handling the visiting team in all different situations? Okay, all things you need to go over at a pre-event timeout. Recommendation number 10, transportation plan should be developed prior. Recommendation number 11, athletes should be transported to the hospital that can provide the most definitive, immediate care. In a cervical spine injury situation, that's a trauma center. Okay, if you aren't taking your athletes to a trauma center, you're doing your athletes more harm, because a regular hospital in a true cervical spine injury situation cannot handle a cervical spine injury. They need to be going to your local trauma center, a level 1, a level 2 trauma center that can handle cervical spine injuries. Going back, recommendation number 3 talks about your evaluation. Okay, do you have an organized, stepwise process? Do you have a process for crowd control? Who's taking care of the parents? When that parent comes screaming out of the stands, my baby, who's going to intercept that parent and take that parent, and what are you going to do with them? Okay, we would always have somebody as designated to grab the parent and lead the parent to the ambulance, or lead the parent off the field to the corner of the field where we're ultimately going to take the patient. And we would explain to the parent, you can do better by being in the ambulance, seatbelted, ready to go when we're ready to leave than us having you walking with us and then we have to get you into the ambulance and we're delaying care when we're ready to leave. How are you activating EMS? Who's doing your primary survey? Who's doing your secondary survey? What are your criteria for calling EMS? What are your criteria for taking them to the hospital? So when we're looking at our primary assessment, obviously we're going to get control of the scene, determine our nature of injury or illness, what additional resources do we need, what's our communication. If we're on the field, are we relying on a walkie-talkie system to EMS in the corner or EMS at the concession stand? Are we utilizing hand signals? What are we utilizing to activate what's going on? Okay, activate, know that our team physician needs to come out, or we need to get EMS here. Making sure that we have clear and concise communication at that point. So when we're thinking about our primary assessment, our primary objectives are circulation, talk about hemorrhage and cardiac, airway and breathing in that order. No longer ABC, but CAB. When we're talking about our primary objectives or our primary assessment, equipment does not matter. It does not matter if the kid is wearing a football equipment or lacrosse equipment or baseball equipment or hockey equipment. It does not matter. Our primary objectives are our primary objectives, and they don't change. So when we're thinking about circulation, we're thinking about ACLS benchmarks, American Heart Association high-quality CPR benchmarks. We're doing a pulse check for no longer than 10 seconds. We're doing high-quality CPR, 100 to 120 compressions per minute, less than a 10-second delay in compressions. Less than a 10-second delay in compressions. So that means if you got to get them on the spine board, less than 10 seconds. You need to get them on the spine board in less than 10 seconds. If you have to get equipment off, you need to get the equipment off in less than 10 seconds delay of compressions, or practice how to get equipment off while compressions are still going on. You want a chest compression fraction, which is the time that you're actually on the chest doing chest compressions. Chest compression fraction of a minimum of 60, but more likely you want a chest compression fraction of 80%. You want to get the AED on them immediately. AED on them immediately. Thinking about and adding to your emergency plan, where is the second AED coming from? Because just because at the beginning of your game you have the AED and you looked at it and it's showing green and it's not beeping, doesn't mean that that battery's not going to fail when you need it. So anytime in your emergency plan, there should be a second AED coming from somewhere so that you have that second AED there, A, for that patient, but also for the next person that drops because of the trauma of the situation. Okay, so add that to your emergency plan. Where is that second AED coming from? And then stay in play versus load and go. Okay? Having that conversation with your EMS ahead of time. All of the research points to that in a code situation, you need to stay in play for 20 to 25 minutes or until you get return of spontaneous circulation. That just because it's a game day, just because it's on TV, just because it's in front of 20,000 fans, doesn't mean that if we have to do CPR that we're going to scoop them up and get them into the tunnel, because I can guarantee you that there's going to be greater than 10-second delay in trying to scoop them up, get them on the spine board, and driving them off the field. And there's a ton of research that shows that you can't do CPR while moving. That's why in a normal, non-athletic situation, if they come to do CPR at your house, they're going to run the entire code in your house until they get return of spontaneous circulation or until they call the code. They aren't going to try to do it running down the road to the hospital. Modern day paramedics, there's no difference between running a code at a hospital and running a code on the field. Paramedics have the same drugs and the same abilities to get return of spontaneous circulation on the field as they do at the hospital. Del Rossi in 2011 talked about the equipment, talked about protective equipment slows the initiation of CPR. You may get increased number of compressions doing compressions over equipment, but your effectiveness of compressions and the recommended depth is decreased. So talking about airway, who's responsible for the airway? Who's responsible for the advanced airway? What equipment are you using? Everybody should have an OPA on them, oropharyngeal airway. They're 60 cents. Okay, they're a great thing if you have an unconscious person that you can throw an OPA in and secure their airway. That's part of standard Red Cross, American Heart Association, CPR for professional rescuer training. Very simple to do, very easy to and cheap to buy, and it helps you. Are we using extraglottic or supraglottic airways? We'll talk a little bit about that. The definitive airway is the ET tube done by paramedics or physicians or RSI. Do you have surgical airway capabilities? Are your paramedics able to do a surgical airway if needed? Again, equipment considerations. Once you have the airway in place, once you have an advanced airway in place, you want to limit the movement of that advanced airway. So if you're there with a paramedic and they put an ET tube in or they put a supraglottic airway in place, that person who's managing that airway becomes the person who's calling for the move. So when you're going to log roll them or you're going to lift them, it's not the person at the head anymore that's saying, counting 1, 2, 3, because that move is predicated on that airway staying in place. Because the worst thing you want to have is that airway move out of place, now you can't ventilate. So that airway technician is the one that's going to call for the move, and you're always rolling the patient towards the airway technician so that they can control that airway. We know the jaw thrust results in less motion compared to head tilt chin lift. Again, equipment considerations, and think about practice. How many people in here practice doing a jaw thrust? How many people have mannequins that you can do a jaw thrust on in practice? So when you're buying your CPR mannequins, that's something to think about. Something to think about collaborating with your local medical school or your paramedics to do your CPR training so that you can do a jaw thrust and you can do it effectively. So some of the research behind advanced airways basically goes all the way back to 2011, showing that laypersons are able to put in a supraglottic airway pretty effectively. So why are we talking about this? Because this is something that's coming for athletic trainers, is to be able to have an LMA or to have an air gel or an air cube blocker or a King airway in your toolkit to be able to put in a supraglottic airway effectively, and that's going to radically change how we manage cervical spine injuries. Because you aren't as worried about the face mask, you aren't as worried about the helmet if you can get a supraglottic airway in, and 99 times out of 100 you can get a supraglottic airway through a face mask. So this is something that's going to change. The research is there from laypersons. Some of these studies, they just walked down the street and handed a supraglottic airway to somebody on the street without any type of instruction, said, here, put this in, and a layperson on the street got it in 98 to 99% of the time effectively. So when we're talking about breathing, ILCOR in 2015 came out with 1 breath every 5 to 6 seconds. The duration of breath should be a minimum of 1 second. American Heart Association ACLS guidelines is a maximum of 12 breaths per minute. There's research showing that when you go to 13 breaths per minute, that has decreased effect. So a maximum of 12 breaths per minute. You talk to a lot of paramedics, they're being taught and drilled on anywhere between 6 to 8 breaths per minute is how they train. Because knowing once the adrenaline gets going, they're going to give a little bit more than 8, but that usually keeps them below 12. If you have an advanced airway in place when you're doing CPR, they're advocating for asynchronized breathing. So that means that person doesn't stop with the compressions. You just breathe for the patient every 6 seconds. There's no more 30 and 2 once an advanced airway is in place. You're just breathing every 6 seconds, and that person's doing their continuous compressions. When we're working with bag valve masks, making sure we have a good clamp. Ideally, the two-handed CE clamp or the two-handed TE or VE clamp are the ones that are recommended. It's not recommended that you do a one-person bag valve mask. It is something that you can do if you need to, but it's not recommended. You're going to get a much better seal and much better ventilation if you're doing a two-person technique. Again, does it take medical training in your whole critical care triangle? Does it take medical training to squeeze a bag? Does it take medical training to do a CE clamp on a face to hold the mask? Those are areas where your coaches can come in handy. Those are areas where your student athletes can come in with your critical care triangle. So some of the research behind bag valve mask, again, two-handed technique has better results. Two-handed bag valve mask has better results than one-handed bag valve mask. So moving on to neutral alignment. Neutral alignment of C-spine produces maximal space available for the cord. The definition is normal anatomical position of the head and torso when one's standing looking straight ahead. We're trying to replicate that when they're in a supine position. There's been some research that this is best made through visual inspection. The pre-hospital care provider is responsible for choosing the amount of padding after that visual inspection that is necessary to achieve neutral position. Some of the concerns, obviously, are contraindications. If they have pain, if they have increased signs and symptoms, if they have resistance, you get a bony block, or they're just apprehensive to you moving them into a neutral into a neutral alignment, you want to stop. But McSwain came up with greater than 80% of patients require anywhere between a ½ inch to 2 inches of padding to achieve neutral position. Neutral position can be reliably observed by the rescuers. The average is somewhere between 1.5 inches of padding, occipital padding for that neutral position. Di Lorenzo, which is probably one of the most cited studies in this, said maximal space available for the cord is obtained with 2 centimeters occipital elevation at C5, C6. Tierney redid that same study in 2002 with a lot more technology. He came back with space available for the cord is greater at 0 centimeters and 2 centimeters. So basically, you have to judge on your athlete what is neutral position, what is the best neutral position, but you also need to be prepared with towels to pack and fill to that best neutral position, whether it be somewhere between 0 to 2.5, 3 inches of padding. You can see there some of the things. No consensus exists for the amount of padding, but you need to be able to judge, and you need to have the towels available to make that judgment and pack and fill as you need. So inline stabilization, 2 different methods, head squeeze and trap squeeze. Head squeeze is what we're commonly taught. Your hand occiputs in the palms. You're able to do a jaw thrust from the head squeeze method. If you need more stabilization, if they're combative, you can go to a trap squeeze method where you're grasping right on the trapezius muscles. You're using your forearms to stabilize the head. Problem with the trap squeeze is it's hard to move the patient. You're going to have to go back to a head squeeze if you're going to log roll the patient, or you're going to lift the patient, or you're going to have to do any type of maneuvers like a jaw thrust. Some of the research behind it, obviously you're going to get less motion with a trap squeeze versus a head squeeze, but it could be difficult for some due to the anatomy, and it could be difficult when you're moving the patient. So recommendation number 6, being familiar with various different types of equipment. Again, your clinical relevance with regards to this. Football players and the management of football C-spine is generally mistaken to be generalized to other sports. The process is similar, but it's not the same. Making sure that if you have multiple sports with equipment, and that includes baseball and softball, how are you going to manage that catcher that has a collision at home plate or collides into the wall while wearing all their catcher equipment with all the equipment on? How are you going to manage that? So NATA recommendations, this is from 2009. You should remove the helmet and shoulder pads should be deferred. This was, again, 2009, should be deferred except when the helmet is not properly fitted. Okay, if you've ever worked lacrosse, you know that lacrosse helmets are not properly fitted. If you've ever worked ice hockey, you know that ice hockey helmets are not the same as football helmets. They're not properly fitted. Face masks cannot be removed in a reasonable amount of time. What's your reasonable amount of time? Is a minute a reasonable amount of time? What do you train to? Do you train to be able to remove a face mask in 15 to 20 seconds? And anything over 15 to 20 seconds may not be reasonable. And what are you going to do when your tools fail? Helmet and chin straps do not immobilize the head. If you cut off a football chin strap, if you cut their chin strap, is the helmet still immobilizing the head at that point? If you take their face mask off and cut their chin strap off, is the helmet still immobilizing the head at that point? 2009, we talked about the all or none rule. Is that still applicable with pack and fill? And then the face mask should be removed prior to transportation, regardless of the respiratory status. So some of the research behind that. 2011, average time spent removing a face mask was 72 seconds. They took about 25 athletic trainers and had them remove a face mask off the patient. The average time it took the athletic trainers to remove the face mask, 72 seconds. Is that acceptable? Is that 72 seconds acceptable if the person's not breathing? Face mask or cordless screwdriver of a lacrosse helmet failed 22% of the time. There's several articles about the cordless screwdriver is the best tool, but a combined tool approach works. If your cordless screwdriver fails, are you going to go to that combined tool approach, or are you going to just take the helmet off? Okay, what is an acceptable period of time for getting access to the airway? This talks about cordless screwdriver. Again, Swartz in 2015, helmet removal results in greater motion than face mask removal. Ride-out 360 took longer than the shut ion. Face mask removal took less time, less motion, less time, and was easier performed than helmet removal with some of that research. So the task force in 2015 came out with this statement, which was probably one of the most controversial statements of that document of, when appropriate in an emergency situation, protective equipment be removed prior to transport to the hospital. Okay, it doesn't say that it has to be removed on the field. It just says prior to transport that you remove equipment prior to going to the hospital. The other recommendation was equipment removal should be performed by at least 3 rescuers trained and experienced. It doesn't say 3 athletic trainers or 3 physicians or 3 paramedics. It says 3 rescuers trained and experienced. So the rationale behind that: improves access to the airway, improves access to the chest, facilitates evaluation in the ER. Some of the research behind it. This was compared 3 different airways on 4 different conditions. It came out with helmet chin strap inhibits quality ventilation, where you have a seal of the mask. This one, chin straps interfere with access to the mandible and proper bag valve mask use. This one, chin straps pose a barrier to establish and maintain a proper seal. So it goes back to what we talked about prior, that if the chin strap is cut from the helmet, is the helmet still stabilizing the head at that point? So but if we have the chin strap on, research shows us we aren't able to ventilate effectively. This one talks about lacrosse. Lacrosse helmet should be removed completely. Chin strap in place resulted in decreased mean ventilation volume. And this was one from 2008. Without a chin strap, the head is free to move in the helmet, eliminating any effectiveness of the helmet. Del Rossi in 2011, again, average of 24.4 seconds to manage equipment and get access to the chest. Okay, so there are all kinds of research available with regards to airway and CPR. This one talks about keeping shoulder pads in place. Decreases main compression depth, and they're talking about lacrosse shoulder pads. Swartz in 2014, helmet removal is faster when you don't deflate the air bladders. This one talks about Rydell ripcord shoulder pads being faster, but a statement in this one is repetition, not training, affected the equipment removal time. So the more times that they did this, the better off they got. This talks about lacrosse. It's better to take the lacrosse helmet off. Again, this one talks about ice hockey. The one study in 1995 says ice hockey helmets should not be removed, but then come back in 2008 when the ice hockey helmet is stabilized, the head in the ice hockey helmet is not stabilized. Recommend helmet and face mask be removed prior to immobilization. Again, bridging the gap with that, what are you going to do on the ice? Are you going to mess around with taking a bunch of stuff off on the ice, or are you just going to get them off the ice and then take care of it off the ice for a non-critical situation? Because you have access to the airway with an ice hockey helmet on. Me personally, if I'm on ice, I'm going to worry about getting them off the ice first and then worry about taking the equipment off the ice. So when we look at pit crew removal, you have an A person, a B person, a C person, a D person. Your A person's at the head. They're responsible for inline stabilization. They're responsible for the commands. They're the ultimate ones that are going to remove the equipment. Your B person is responsible for your evaluation. The B person is the first person to cut. They're going to cut the midline of the jersey or shoulder pads. They're going to be the person that you're going to transfer inline stabilization to. Your C person cuts down the midline, whatever the B person didn't cut. They're responsible for cutting on one side of the patient. The D person is responsible for cutting on the other side of the patient. So if you're on the left side of the patient, you cut everything on the left side. If you're on the right side of the patient, you cut everything on the right side. Again, our communication with this, be intentional. Make sure that before you clear the ears, you pause and let the person know that you're about to clear the ears so you don't get a rebound effect. Spinal motion restriction, two different methods. Collar method, where you're going in, one hand over top, one hand at below, forming a collar with your hands to provide that stabilization. I prefer the bilateral mastoid cupping method, where you're coming in, you're resting your forearms on their chest, and you're circling your hands around their occiput to be able to stabilize the cervical spine in that method when the helmet's being removed. So shoulder pad removal, two different methods: flat torso method, elevated torso method. You also have your bivalve pads, which is your ripcord method, and the log roll method, which I don't really recommend. I'm a big proponent of the flat torso method because I'm choosing one method no matter what's going on, whether or not I'm removing pads from a stable athlete or removing pads from an unstable athlete. I'm always doing it while they're on the ground. It takes less people than worrying about trying to elevate their torso. You aren't trying to elevate a 350-pound person's torso when they're sweaty and wet. You're just removing them on the ground or while they're on the backboard. So Rydell ripcord shoulder pads, I don't know how many of you have seen these on your athletes. The one thing, they have a ripcord there. It's always on the left side. It's always zip tied to the shoulder pad. The one thing I'll recommend is go to the hardware store, get the little mini zip ties, and before the season, cut off the zip ties that the manufacturer puts on there. Rydell tightens the zip ties very tight, so it's very hard to get scissors underneath at a zip tie. You can cut that off, put your own zip tie on where it's a little looser. You can make sure your scissors can get underneath there in a time of emergency. So the technique, NATA method, which is either flat torso or elevated torso, is recommended. All three techniques produce motion. The ground-based method, or the levitation method, which is basically the elevated torso method, produces less motion than the log roll. Rydell ripcord shoulder pads are faster. Took less time to remove. This study in 2012 talks about the pack and fill method, that if you have to remove helmet in the field, despite what we've all been taught about all or none principle to remove both the helmet and the shoulder pads. You can use a pack and fill method with towels, and it's been proven effective to use a pack and fill method too if you can't take the shoulder pads off right away. Face mask removal, some of the bridging the gap, appropriately trained personnel. Who's appropriately trained? How many screwdrivers do you have out on the field at any time? How many pairs of scissors do you have out on the field at any time? What's the harm in if you've identified coach B, C, and D to be in your critical care triangle, what's the harm in handing them a pair of scissors at the beginning of practice or the beginning of the game so that if something happens, everybody has scissors on the field that's able to start cutting? How are you removing the face mask? What's your reasonable amount of time? If the quick releases fail, if your screwdrivers fail, are you going to go to a cutting tool, or are you just going to take the helmet off in that situation? Thinking about that. Again, what 3 rescuers are trained and experienced? When are you going to remove the equipment? Is it going to be on the field? Is it going to be once you get to the ambulance? Is it going to be in the back of the ambulance? Is it going to be in the tunnel? Or is it going to be at the hospital? And then 2 schools of thought with removing equipment. The first school of thought is remove only that equipment which is in your way of your critical objectives. So if you have to do CPR, all you're doing is cutting open the shoulder pads, getting on the chest. If you have to do airway, that's when you're going to remove the helmet. The other school of thought is complete equipment removal right from the beginning and then manage what they're doing. Neither school of thought is wrong. Okay, again, there's no such thing as always and never. It doesn't matter what you subscribe to, just make sure that you're practicing. One thing that we've gone to teaching and I think has worked very well is establishing that team leader, that code runner, that's able to not be involved in the management, but is able to stand up and see everything from a 360-degree perspective and make sure that everybody's doing their thing. That's not likely going to happen at the immediate management, but it's likely to happen once EMS and once the fire department gets there, that there's somebody that's standing back at the head and is able to pinpoint and tell people to do certain things. So if you're looking at a no-pulse situation, that person at the head, their job is inline stabilization, their job is a pulse and breathing check. When you go to remove the helmet and shoulder pads, their job is remove the helmet and shoulder pads. Person at B situation is they're cutting down the jersey. And they're the first person on the chest as soon as the shoulder pads are splayed. They're CPR. Person C, they're getting the rest of the cuts done when it comes to inline stabilization transfer. They're the ones that are going to be removing the helmet and shoulder, or inline stabilization transfer. They're the third person in CPR. Person D, they're getting a defibrillator. They're setting it up. They're responsible for the defibrillator. They're CPR number 2. So after that initial shock, after those 2 minutes, they're hopping on the chest. Current AHA guidelines, you don't have to worry about breathing the first 2 to 4 minutes of active CPR. So we're on the chest. We're doing 200 to 400 continuous compressions. Okay, we aren't worrying about breathing. After the AED gets there, we're going to worry about, and we get the AED set up. While we're doing compressions, we're going to get the equipment off. Okay, compressions should not stop to take equipment off. You should be able to get equipment off while compressions are being done. For a non-breathing situation, they have a pulse, but they aren't breathing. Same thing. Person B, C, and D are going to be responsible for getting the shoulder pads cut but not removed. They're going to be responsible for the airway. They're going to be responsible for the bag valve mask, squeezing the bag valve mask, and the defibrillator. Talking about rigid cervical stabilization collars, again, a controversial topic. There's conflicted evidence and support. I think this will be something that you'll see in current EMS about, are you using a cervical collar, are you not using a cervical collar? Tons of adverse effects or events in the research regarding it. The biggest thing is increased intracranial pressure and tissue necrosis with regards to cervical collars. Again, tons of different research that talk about the application of a cervical collar, the challenges behind a cervical collar. There's some research with regards to they're poorly applied. Only 11% of EMS professionals and physicians applied the collar correctly. So our bridging the gap with that, have a selective approach. Collars are safe to use in the majority of patients, but there are going to be some patients where a collar is not going to be safe to use, making sure we're doing that, making sure we're monitoring the patient appropriately. Talking about spine boards. Patients, the task force recommendations, another one of the controversial topics with regards to the task force. Talking about that athletes should be transported on a spine board, where current EMS standards are spine boards used as an extrication device but taken out once they get on the stretcher. So tons of evidence about spine boards. It's a paradigm shift in a lot of athletic trainers of we're so used to a cervical spine injury goes on a spine board. They're fully locked down on the spine board. They shouldn't be able to move. Tons of different research about it, about airway compromise and aspiration and increased intracranial pressure. Basically what national EMS has gone to is selective spinal immobilization. If they have motor and sensory deficits, anatomic deformity, severe pain, altered mental status, they're going to go on a spine board. We've moved to the term of spinal motion restriction now, which is basically a cervical collar and they put on a stretcher cot. A lot more scoop stretchers are coming into use, just because scoop stretchers are easy to take out. And a lot of research has shown that a cervical collar on a ambulance cot is just as effective as a spine board without all the negative effects. So what's our bridging the gap of that? Communicate and work with your EMS. When you call EMS, it's their patient. It's not your patient anymore. It's their patient. If they want to take the spine board out from underneath the patient, it's not the time to get in an argument with them. Let them take the spine board out from underneath the patient. Okay? It's their patient. Let them handle it the way that they're going to handle it, but have that communication early. Scoop stretcher, again, some research coming out about scoop stretcher causes less motion. This is the combi board made by Hartwell. This is what we currently use at Michigan for football. It's basically made out of spine board material but functions as a scoop stretcher. You can use it as a spine board. We can leave it on there and it functions the same way as a spine board would, as your regular rigid spine board. But also you can scoop them up, and if we need to take it out from underneath them, we aren't log rolling them twice to get it out from underneath of them. Vacuum mattress, again, something that's been used in lieu of traditional spine board. It's big, it's bulky, it does have some advantages to it, but can be expensive, can get punctured pretty easy. Vacuum pad is something, again, made by Hartwell that you can put on top of a rigid spine board that gives you a little bit of cushioning. You can use it as head immobilizer, molded around the head. Some of the research behind it with regards to comfort and tissue pressures, that with vacuum devices, the comfort increases, tissue pressures decrease, symptoms reported decrease, and stability is equal to what a spine board would have. Some of the research into transfer techniques, increased motion with a log roll compared to the lift and slide. 8-person lift, the lift and slide, making sure our board positioning is good, our rescuer positioning is good. We have adequate room. How high to lift? You can lift them directly up to the gurney if that's what you're going to do, instead of lifting them on a board as a way to do it. Again, this requires personnel. This requires training. Supine log roll, board positioning. What I like to do with our supine log roll is put our board 18 inches superior to the top of the head, and we'll talk about that a little bit in a couple slides with regards to repositioning them on the board, but I like to have it superior to the head, so we're only doing it once. Prone log roll, you have the prone log roll push versus prone log roll pull. Push is shown better in research than the pull. Here's an example of the push, where you're kind of pushing the person prone onto the board, versus the pull, where you're kind of pulling the person towards you and you have the board in between you. So centering. You see here, this is a study that just came out in 2015 that actually shows that horizontal adjustment, so once they're not centered on the board, actually pushing them horizontal actually resulted in less motion in the cervical spine. We've all been taught that we never go horizontal, we always go in line. I don't like the horizontal. I think there's too many opening for problems. That's why I always put the board 15 or 18 to 20 inches above the head, so that all I have to do, instead of having to do a V slide or diagonal slide, all I have to do is slide them up. I don't have to slide them back down to slide them back up to get them centered on the board. Transportation, this just came out talking about carefully considering your vehicle specifications, your terrain and route, if you're going to take them off the field on a gator or off a med bed versus having an ambulance drive onto the field. So bridging the gap, again, which technique are you going to use? How are you going to position the person on the spine board? Who's your personnel? How many are there? What's your experience of training? What are your communication? What are your commands? Again, thinking about what's a reasonable period of time. How are you going to educate your coaches? Who are appropriately trained personnel that you're going to have there at all different times? So our clinical bottom line, again, there's no such thing as always and never. Make sure we have options regardless of the situation. Make sure we have relentless preparation and planning and consistent training with that. Our take-home messages have a team approach. Leave your ego at the door. Expect the unexpected. Make sure we're practicing this in a stressful environment. If you have 30 seconds to get the equipment off, make sure we practice to taking the equipment off in 30 seconds, not just, oh, it takes us 2 minutes to get the equipment off today, and that's going to be okay. Again, in times of stress, you always fall to the level of your training, not rise to the level of your expectations. Any questions? I know we're a little close on time. Any questions? Yes? It's challenging. You just have to make sure that's when that extra person comes in. Of you aren't trying to do one person BVM with that, where you can have a good person that clamps down on the seal. And really, it's not so much the seal, it's more of opening the airway. If you get a good opening, a good jaw thrust of opening the airway, facial hair is really not going to make a difference. Any other questions? Yes. I usually always, with a prone athlete, I'll usually roll them as soon as possible because I don't want to take the chance. I'd rather roll them, get them prepped for transport, and assess them than worry about them in a prone situation. If they're prone for me and you have great breathing and they're talking to you, I may leave that person prone. But if they're unconscious, I'm rolling them right away to be able to open up the airway. Any other questions? All right, thank you.